Now we move on to the session 1. That's a female genital dermatosis. I invite the session coordinator, Dr. Manogna. So, Dr. Manogna, please go ahead.
Respected dignitaries, estimated members of the organizing committee, and all the delegates and all the faculty members, a very good morning to one and all. It gives me very great pleasure to welcome you all to the first session of ASTICON 2021. And the topic for this session is female genital dermatosis. I'm sure this session will prove to be a feast of knowledge with a wide variety of clinical topics. And first and foremost, I would like to welcome the chairpersons for this session. Dr. R.M. Datta sir, our first chairperson, is the ex-professor in HOD, IPGMR and SSKM Hospital, Kolkata. Sir has held various positions in IADVL and was also the past national president of Indian Association of Sexually Transmitted Diseases and AIDS. Sir, I request you to please ascend to the dais, sir.
Yeah, good morning.
And kindly permit me to introduce the second chairperson, Dr. T.S. Chandragupta sir, who is a retired professor of DVL and has studied in Kurnool Medical College and later has done his post-graduation also from SV Medical College as well as Kurnool Medical College. Sir has 4 national publications and has trained and taught a lot of postgraduates. Sir, I request you to kindly ascend to the dais, please. Please permit me to introduce our third chairperson, Dr. Vijay Zawar sir, who is a candidate for President-elect 2021. And sir is professor in HOD Dermatology, Dr. VP Medical College, Nashik, Maharashtra. Sir has held various academic positions in IADVL. Sir, we request you to kindly ascend to the dais.
Thank you very much.
I request our chairperson, Dr. R.M. Datta sir, to kindly introduce the first speaker of today's session, Dr. JVDS Prasad sir.
Good morning, everybody. And I thank the organizing committee to put me in this position at present. Now, the biodata of Dr. JVDS Prasad. He has done his MBBS MD from SV Medical College, Tirupati, and assistant professor of Guntur Medical College, Guntur, and SV Medical College, Tirupati. He is also the associate professor of Osmania Medical College, Hyderabad, and professor of Osmania Medical College at Hyderabad. He has 8 publications till date. And welcome, Dr. JVDS Prasad. I hand over the mic to the organizers.
Over to Dr. JVDS Prasad.
Yeah, sir. Yes. Good morning, all. Welcome to the day of palindrome. Today is 12/9/21. So either way, it is the same number, and it mimics the STA transmission. If a male is having STA, they are transmitting to female, their partners, and if a female is having STA, they are transmitting to their male partners. And this is how today correlates with our conference. Thank you all for the ASTICON for giving me the opportunity to take a session on this female genital dermatosis, of which my topic being the genital practical evaluation of the vaginal discharges or genital discharges in a female. So let's have a little bit of induction into the subject proper with introduction on the subject about the genital discharges. So usually in a reproductive age woman or any woman, if they see the discharges coming from the vagina, they will perceive it as a vaginal discharge. Any discharge from the reproductive system, that will be perceived as a vaginal discharge by women, and they assume that it is a pathological one. That is the main problem. And of course, there are so many structures that are contributing for the vaginal discharge or genital discharge. It is the vagina and cervix are the 2 common organs which contribute for the majority of the discharges. And whether from the side from where the discharge is coming, or it can be easily distinguished by performing a simple perspective examination under the privacy and the confidentiality. And most of these infectious discharges may be transmitted from one person to other person to their partners or to their sexual partners through unprotected sexual intercourse. And if once these infections are not treated or incomplete treated, they may result in either local or systemic complications. And more importantly, the presence of genital discharge causes a lot of inconvenience to the partners of the sexual partners in the form of transmitting the infection and also in the form of the sexual distress, wherein the activity will reduce from 3 times a day to 3 times a week to 3 times a month. So this is how these genital infections or genital discharges will contribute in the transmission. And when it comes to the natural defenses, it's really a big slide to discuss topic. But however, I recommend you to go to Kinky Holmes textbook of STD, where a big chapter is given on the genital mucosal defenses. And here, I would like to mention that it is a to simplify that natural defenses, it is the multi-layered stratified squamous epithelium of the female genital system act as one natural defense mechanism. And presence of no glands in the vaginal walls will also contribute. And most of the time, the vaginal pH, which is acidic in nature, under the influence of estrogen throughout their reproductive life, is one of the major defensive mechanism contributing for the prevention of establishment of infection in the genital tract. So this is the matrix that we have to understand. So on the left side of the screen is women in the different age groups, the neonate, the infant, the prepubertal age group, reproductive age group from menarche to menopause, and the postmenopausal age group. And right side is the type of the discharge that we see in women. It's a physiological discharge, or it may be a reproductive tract infection, which is not connected with the sexual activity. And then sexually transmitted infections, the presence of the forgotten or foreign bodies, and certain pre-malignant and malignant conditions. So if you see this matrix, combination matrix, so these are the categories of women who are more likely to have these kinds of the discharges. The neonate, infant, and prepubertal women are more susceptible for 1 to 4 types of the discharges, whereas in reproductive age group women from menarche to menopause, they are susceptible for all kinds of the discharges, whereas the postmenopausal women, the 2 to 5 numbers are more common, of which the 5th is the most seen or commonly seen in this postmenopausal women. Next, coming to the evaluation of the genital discharges. So the causes are divided into 2 categories, basically the physiological and pathological. Here I would like to give a little brief idea about the physiological and pathological discharge in men also. The physiological discharges in men are happens to be the smegma, is the number 1 cause in uncircumcised men, and spermatoria, mostly in low sexual activity or no sexual activity women, and prostaturia and phosphaturia. Whereas the pathological discharge in the men contributes by mostly of the sexually transmitted infections. They are gonorrhea, chlamydia, and in a woman and a partner of a female partner who is suffering from trichomonas vaginalis is likely that men will also conduct the disease, and it will manifest in the form of the urethral discharge in addition to the gonococcus and chlamydia. Then in women, if you look into the physiological aspects of the discharge, it is in different age periods, the premenarchal, periovulatory, and premenstrual, and during sexual excitement under the influence of the cervical secretions, they will have more discharge. And during sexual activity, because of the Bartholin's secretions to lubricate the sexual activity, we'll see more of the discharge under the pregnancy is one. When it comes to the pathological discharges, I will limit my attention to only these 5 conditions, wherein the candidiasis, trichomoniasis, and bacterial vaginosis are principal causes for the vaginitis or vaginal discharge, whereas the gonococcus and chlamydia are responsible for the cervical discharge. So these are the 5 infections which I limit in this 15 minutes to discuss upon. As far as concerned, the vaginal discharge or genital discharge to the women is concerned. So if you look into the physiological causes of the discharge in different age groups, during the premenarchal age, usually before 1 to 1.5 years prior to the onset of the menarche, the girls will have more amount of the discharge, which is non-venereal in cause origin, and the causes are mostly non-specific bacterial infections, and maybe of late forgotten foreign bodies, and rarely vulval and vaginal tumors that may contribute for premenarchal genital discharges. and they usually manifest with clear, serous or mucoid discharge associated with little bit of soreness and itching. Whereas in premenstrual or pre-ovulatory period, this kind of the discharges are seen during the reproductive age group from menarche to menopause, and they are of this kind of the type. They are white, they're clear, non-homogeneous, and they are of a serous in type. And on examination, what we'll see under the microscopy, the facilities are available. We'll see only normal epithelial cells associated with the predominant lactobacillus, which are helping bacillus for the female genital systems. And when it comes to the discharge due to sexual excitement, we'll see the contribution of the cervix, and also we'll see the contribution of the Bartholin's for the increased vaginal discharge during the sexual act. So next is the evaluation of genital discharge, and though I told you about the physiological, pathological, and of which pathological there are 5 causes, we can come to a 50% or 60% of the diagnosis by taking a detailed history of the in the patient, where we must be in a position to listen to the active listening process should be there for the story what they say, what the patient will tell us. And also, we must be in a position to evaluate on these lines. So, is a history of age. In the history, we'll focus upon deriving certain important information on these lines: the age and the marital status, the site and type of the site from where the discharge is coming out of the patient could be able to tell us, and then the type of the discharge, which type of the discharge they are seeing, whether it's adherent discharge, whether it's free flowing discharge, like that, and the duration of the discharge. So how long is it, for days or weeks, or is correlated with their menstrual period, something like that, and the timing of the discharge. And also we'll ask into the associated symptoms with the discharge. Is there any itching, or is there any dysuria, or is there any dyspareunia? If at all dyspareunia is there, it is superficial or deep. If dysuria is there, how frequently it is associated with any passage of the urethral discharge also. All those questions, associated symptoms, we will ask the patient. And then we will ask the occupation of the patient and their spouse. Sometimes the risky, the spouse from the risky occupation background will contribute for the frequent or recurrent vaginal discharge in women. And also the sexual orientation practices of the patient and their partners. Of late, the times have come where the oral sex and the anal sex also are coming out with the normality in sexual practices. So asking for the in detail sexual orientation practice of the both patient and partner is also very important. And is there any history of the previous episodes? The similar kind of the previous episodes there in the patient that will give us a clue to whether the patient is compliant to the previous treatment or not. And is there any drug treatment in the past, or any drug reactions in the past from medical legal aspect to protect our skin? And also, is there any operative procedures is done on the patient for the reproductive system problems, wherein we can evaluate whether the cause is because of the forgotten foreign body or something like that. And also, we'll ask for the workplace environment and people associated with that workplace environment, where there may be some cause in the genital discharge of this patient. And also, we'll ask in detail about what are the increasing factors and the decreasing factors that influencing the genital discharge in a woman. So these are the angles in which we will take the history. And if further we want any detailed history, so these are the few lines that where we'll go for the detailed history, in addition to that points I mentioned in the previous slide. So when it comes to the examination, after completion of the history, we'll go for the examination. This examination is nothing but the examination of the doctor for about the accuracy of his diagnosis. So there are 4 types of examination. One is visual examination. Second one is perspectival examination. Third one is pervasive examination. Fourth one is a laboratory examination. So in visual examination, what we do? So this is what we do in the visual examination. So we'll see whether from where the discharge is coming out, the color of the discharge, and its adherence nature. The adherent discharge is telling us, giving us a clue that it could be a candidiasis or it could be a bacterial vaginosis. And if the discharge is free flowing and it is adherent, I mean it is going in between the labial folds, labia minora, labia majora, and 2 labia minora folds, then it could be a case of the trichomonas vaginalis, where the fluid is going through that negative surface tension. So that way we can make a diagnosis. And third one is, next we'll examine the perineum and perianal area, wherein we'll know the practices, sexual practices, and also the risk of contracting the recurrent candidiasis from the anal cavity. And also we will look for any associated erosions, ulcers, inguinal lymphadenopathy because in STIs, the mixed infections are being more common. Here, the mixed infections means having more than one type of the infection, STIs, and we call it as a mixed infection. In STIs, mixed infections are being more common. We look for other STI presentations like presence of erosions, ulcers, and inguinal lymphadenopathy. And also, we look for any senile changes in the vulva, where this will give us a clue the possibility of the risk of our patient for the malignant or pre-malignant condition.
Accept my apologies, doctor.
Yes.
We are left with 3 minutes.
Sorry, sir. So I'll make it fast. So then perceval examination, these are the areas that we look into: the vagina, the cervix, and the urethra for various kinds of this one. And in examination, the NACO tells us perform the minimal laboratory if it is available, litmus test, wet mount, 10% KOH, weak test, Gramscian, and also VDR, which is a mandatory test after they perform the counseling and testing. So I will skip all these individual slides. And this is how this is what I emphasize upon. Please follow the NACO flowchart on the management of the vaginal discharge, the cervicovaginal discharge, wherever it is possible, and look for the vaginal causes and the cervical causes, and treat the causes accordingly with the kit number 1 and kit number 2. And this is the NACO 127 kits chart, where the kit number 1 is advised for the cervical discharge of gonococcus and chlamydia, whereas kit number 2 is advised for the vaginal causes of the candidiasis, BV, CV, and PP. So, and partner treatment, wherever you treat the candidiasis, cervical discharge, you treat their partner with the kit number 1, and wherever you treat the patient with kit number 2, you think and you examine their male spouse, and then you decide accordingly. So, in summary, so evaluation of genital discharge in female is a simple and effective OPD procedure that we can do it. The evaluation can be done across all healthcare facilities where it requires a minimal equipment like speculum and light resource, a little time and more of the commitment from the healthcare worker. And syndromic case management is an effective way to resource poor settings with availability of single therapy dose color-coded schedules, kits like a kit 1 and a kit 2 in case of vaginal discharge and reproductive. Thank you, and I thank all these people for textbooks, the authors, and more importantly, Dr. B. Masudan, he's a technical expert for facilitating the preparation of the slides. Thank you all.
Thank you, sir, for a wonderful talk with clinical tips which were beneficial, not only for postgraduates, but also for practitioners. I now request our chairperson, Dr. T.S. Chandragupta, sir, to kindly introduce the speaker for the second topic in today's session, titled Clinical Pearls in the Diagnosis of Genital Ulcers. I request sir to kindly introduce our speaker, Dr. S. Kalaivani, ma'am.
Chandragupta sir. Dr. Chandragupta sir, are you there?
Let Dr. Jawar do it.
Yeah, please. Dr. Jawar sir.
Vijay can do it. Vijay?
Yeah, I can do it.
Yeah, please.
Vijay, please.
Dr. Jawar is there.
Okay, I will do it. Don't worry. So good morning, everyone. At the outset, let me congratulate Dr. Umesh and the team of ASTICON for a stupendous success. This is one of the most vibrant online conferences that I have witnessed in the recent times. It's my pleasure and privilege to introduce Professor S. Kalaivani. She is Director and Professor of Dermatovenerology at Madras Medical College. She has been extremely academic with quite good number of international and national publications as well as presentation. She has received many honors and awards, including Silver Jubilee Oration Examiner at various universities. She is also NACO trainer for the medical and paramedical staff in various STI and RTI programs, and her area Over to you, Dr. Kalaivani. Are you there, please? Ma'am, there? Audible?
Kalaivani madam, over to Dr. Kalaivani.
చెప్పేసి నా పోస్ట్ ఏం చేయాలి ఇప్పుడు నేను
మీరు
Srinivas, you stop sharing, then she will.
Yes.
Dr. Kalaivani, ma'am, please share your screen. Yes.
Ma'am, sorry, we can't hear you.
Unmute, ma'am. You need to unmute, please.
Madam, not here.
Ma'am, remove your headphones and speak and see.
Your slides also not coming.
We are unable to hear your voice, ma'am. Please.
Am I now audible?
Yeah, perfect.
Okay.
Please share your screen.
Okay. Good morning to one and all. So, diagnosis of genital ulcer. Genital ulcer can be due to venereal or non-venereal causes.
Please share your screen, ma'am.
Yeah. I have started, sir, already.
No, your slides are not visible.
In the down, there is share screen is there. You click on that, then
I have done that. Naren?
Green button, ma'am.
Yeah, I have done, sir. Naren? Naren?
So after the green screen, ma'am, you need to click share.
1 minute, sir.
Select your slides and share.
Have you minimized your slides already?
Yeah. I have minimized, sir. Yeah. Is it coming now?
Yes.
Yeah? Okay.
Yes.
Sorry for the inconvenience, sir.
Just speak loudly, ma'am.
Venereal causes include syphilis, chancroid.
Madam, slideshow, madam.
Yeah. Yes,
perfect.
So, venereal causes include syphilis, chancroid, herpes dentalis, granuloma inguinal, and primary stage of LGV. Non-venereal causes include trauma, any drug reactions, vesiculobular skin diseases, Behçet, Reiter's, Crohn's, and pre-malignant and neoplasm. So, always privacy and confidentiality should be maintained for the patient right from the entry to the exit of the STA clinic. The history taking and clinical examination has to be done properly by a qualified person who is non-judgmental and non-moralistic attitude. So general information like name, age, sex, educational status, and occupation, residence should be asked thoroughly. Then the chief complaints. If the chief complaint is of genital ulcer, the onset, duration, progression, associated with pain or painless, associated with itching, discharge, associated with constitutional symptoms, bleeds on touch or manipulation, any history of previous fluid-filled lesions on the genitalia, any history of trauma, any history of vaginal or anal discharge, any history of hair loss, any history of numbness or pain over lower limbs, because you have to elicit in detail to rule out the non-STA causes also and the local complications due to the genital ulcer. So treatment history for the present complaint is very, very important because tablets, injections, and ointment can change the clinical picture of the present clinical condition. Marital history, you have to ask when she was married, what is the duration of marriage, whether living with the spouse or separated. Sexual history is very important and it has to be asked in detail. When was the last marital contact, to know the incubation period. If there is extramarital contact, you have to ask about whether it is with a known or unknown, unprotected or protected, which side, and what was the mode of sex, when was the last contact. Premarital contact also you have to ask. In unmarried, you have to ask the last sexual contact details. These children, always when they present with genital ulcer, kindly ask about the sexual abuse history. Don't think it is a cause of non-venereal. And obstetric history, you have to elicit number of pregnancy, live birth, and any history of abortion or stillbirth. Menstrual history, the menarche, and the last menstrual period. Past history of past STDs is very, very important. Is there any recurrence? If so, what was the diagnosis? Any previous STIs was there? What was the treatment given? Whether partner was treated? And any medical conditions the patient is suffering from, diabetes, hypertension, tuberculosis, any history of blood transfusion or previous surgeries. Is the patient is on current medications or any drug allergy? General examination should start from the head to foot and recording the vitals, and all systemic examination should be done. Local examination should start with the inguinal region, look for presence of any swelling, ulcer, sinus or scar, and then palpate for the lymph nodes. And in the external genitalia, if you see the ulcer, genital ulcer, the side size, shape, whether it is single or multiple, painful or painless, the base, the borders, the edges, the floor, whether bleeds on touch, should everything be examined on palpation. The external urethral orifice also should be examined for the presence of any ulcer, discharge, erythema, and edema. Perineum, perianal region, skin, oral, and anal mucosa have to be examined carefully. Bones and joints for the presence of any swelling, tenderness, or any restriction of movement. Where vaginal examination has to be done, if vaginal discharge is found, you have to elicit all the color consistency like that. Speculum examination has to be done with a Cusco's bivalve self-retaining vaginal speculum. Look for the cervix, any erosion, edema, erythema, discharge, do the necessary investigations. Bimanual examination to rule out PID. Rectal and proctoscopy in case of anoreceptive female individuals. So primary chancre usually to be single, can be multiple also. So usually it will be painless, clean base, the clean floor with a base indurated, local lymph nodes will be involved. Always put a speculum because primary chancre can occur as a erosion in a cervix in 10%. Chancroid, it presents as a multiple painful ulcers with undermined or ragged edges with bleeds on manipulation, and the lymph node involvement will be an unilateral inflammatory bubo which can occur 1 to 2 weeks after the appearance of the ulcer. Genital herpes usually starts with the constitutional symptoms and the appearance of grouped vesicles in the genitalia which break down to form multiple painful superficial ulcers which can be coalesce to form a polycyclic border. In case of HIV positive, this genital herpes can remain for a long time. It can become a chronic and atypical condition, so the treatment has to be prolonged. Donovonosis caused by Klebsiella granulomatous can look like can mimic as a carcinoma. So it will be a single or multiple with a beefy red granulation ulcer with bleeds on touch and no inguinal lymph node involvement will be there. So these are the few descriptions which have been given for all the genital ulcer which are the causes for STD. So primary lesion will be a papule in case of syphilis and other condition except herpes. Then the base will be indurated in case of syphilis. The pain will be absent in all the conditions except herpes and chancroid. Lymph nodes will be absent in case of donovonosis. Recurrences is common in case of herpes. So lab diagnosis, what are the bedside investigation you can do? You can do a dark field microscopy. So you have to clean the ulcer, take the serous exudate, look it under dark field microscopy. The organism, the left picture shows the typical Treponema pallidum. They have a regular coils, they stay in the field for some time. The right side picture shows the non-pathogenic treponemes. They don't have the regular coils and they don't have a typical movements. So negative dark field examination means the number of organisms may be less. The patient may have applied some topical antibiotics, or they may be suffering from mixed infection. So DFA TP also can be done. Serological test, non-treponemal test, VDR and RPR, and treponemal test or specific test to rule out syphilis. So VDRL sensitivity is 70 to 90% and TPPA is 94%. So gram stain for chancroid, it is usually a diagnosis of exclusion. You can do a gram stain by taking a swab from the undermined edges with a calcium alginate swab and look for presence of multiple pus cells with gram-negative coccobacilli appearing in short chains. Herpes, if there is a vesicle, deroof the vesicle, scrape the base of the ulcer, do a Leishman stain, look for the presence of multinucleated giant epithelial cells and intranuclear eosinophilic inclusion bodies. Granuloma inguinale, you should do a tissue smear. Here, you have to take it from the edge of the ulcer along with the normal skin, and you have to stain it with a Leishman or a Giemsa stain. Look for the presence of large mononuclear cells with a eccentric nucleus pushed to one side, with numerous intracytoplasmic vacuoles inside this. You can see the mature and immature forms of Donovan bodies. Immature forms look like blue or blue-black condensation of bipolar chromatin condensation on either side of the organism, giving a closed safety pin appearance. So LGV, usually we cannot see the transient ulcer in the primary stage, but if at all you see, you can do a Giemsa stain. So Trichomonas vaginalis and Candida can present as a multiple, superficial, painful in the sense external, it can cause external dysuria, so the ulcer may be painful for the individual whenever they pass urine. So here you have to do a Trichomonas vaginalis investigation by taking a wet film from the ulcer. With 1 drop of normal saline, you should look for the presence of Trichomonas vaginalis, a typical pear-shaped organism with a jerky motility. For Candida, you have to do a smear with gram stain or with 1 drop of 10% KVH. Look for the presence of pseudohyphae and spores. So what are the take-home messages? So privacy and confidentiality forms an integral part in the STA diagnosis, and proper history taking, because you can exclude certain non-STA causes when you take a history properly, and you should spend more time in eliciting the history. Detailed sexual history, not only of the patient, always you have to examine all the sexual partners, because we miss this angle always. And complete physical examination from head to foot should be done. Even though
Apologies, Dr. Kalaivani, ma'am. We are 3 minutes from the schedule.
Yeah, I will finish. So primary chancre can present as an erosion in cervix. So always use a pipette to withdraw the serous exudate and look it under dark field microscope. So don't think it is an erosion in cervix. For all genital ulcers, do dark field microscopy, gram stain for chancre, Leishman stain for genital herpes, and a tissue smear to rule out donovonosis. Biopsy is needed only for chronic atypical progressive genital ulcer after ruling out immunosuppressive conditions, and in case of donovonosis to differentiate between the carcinoma. All genital ulcer patients should be screened serologically with blood VDRL followed by specific test and rapid test for HIV after pre-test counseling. In high-risk patients, you have to do blood for HBsAg and anti-HCV in addition to the above test. Thank you. I thank the organizers as well as the chairpersons for giving me the opportunity. Thank you.
Thank you, ma'am, for a very illuminating talk. A wise man once said, "Knowledge shared is nothing but knowledge squared." With this quote in mind, let us proceed to the panel discussion on the topic of vulvar pain, malignancies, and role of surgeries. I request the Honorable Chairperson, Dr. Vijay Jawar sir, to kindly introduce the moderator for this panel discussion.
Hello, am I audible?
Yes, sir.
Okay. Thank you, Doctor, for inviting me to introduce and invite my good friend, Dr. Neena Madnani. She is a consultant in PD Hinduja Hospital and Sir H.N. Hospital at Mumbai. She has been extremely interested in the vulval dermatosis, and she was the first to establish the first vulvar clinic in India. She has published several articles in peer-reviewed journals and chapters in various textbooks. She was initiator and the coordinator of the first special interest group known as female genital diseases in 2018 and 20, and it has achieved a wonderful level of academics throughout the curriculum of the throughout the tenure of her special interest group. She has received several awards and orations, and she has multiple lectures in CMEs across India and abroad on this subject. She has planned and coordinated several CMEs on vulvar diseases for dermatologists and gynecologists conferences. So we have a wonderful faculty today, Dr. Neena Madnani. Please come over the dais and take the charge as moderator for the panel discussion. Over to you, ma'am.
Thank you very much, Dr. Zawar. I'll just start sharing my screen. So good morning, everybody, and happy Ganesh Chaturthi to all of y'all. I am very privileged to be here at this very important conference, ASTICON, amongst all the luminaries. And I was very happy to hear the first few lectures by Dr. Somesh Gupta, Dr. Datta, and Dr. Vani, which emphasize what I believe in, that it is very important to diagnose what you're looking at for better patient care. I would like to thank Dr. Bhumesh Kumar and the Telangana team for giving me, and on behalf of my panelists also, to let you know that we are very privileged to be part of this panel discussion. Our panelists are all luminaries, and what I'm happy is they have a passion for vulvar disease. We have Dr. Dhanashree Bhide, Dr. Smita Prabhu, Dr. Kavita Thota, Kavita Raj, and Dr. Nirmala Devi. Dr. Dhanashree Bhide, she is attached at present at KM Hospital and Dinanath Mangeshkar Hospital, Pune. She has a lot of achievements and awards. She was awarded the B.B. Gokhale Award for the first rank in Pune University, authored 7 publications, and her areas of interest are dermatology, clinical dermatology, lasers. She's a scientific committee chairperson of Dermacon 2020 Pune, which was very successful, and president of the Pune chapter of IDVL. And she's a Maharashtra state branch and a member of the present SIG female genital dermatosis. Our next panelist is Dr. Athota Kavita. She is presently affiliated as a dermatologist to Paruchuri Rajaram Memorial Skin and Laser Center, Guntur. She has a number of presentations in many state and national conferences. She has awards and honors and achievements and has won the IDVL Scholarship 2016, the Jignasa Award, Andhra Pradesh, Cuticon 2019, Fulford Derma Foundation Award, and her areas of interest are clinical dermatology, female genital dermatosis, and lasers. Dr. Nirmala Devi is presently affiliated as professor and HOD in DVL, Tirunelveli Medical College, Tamil Nadu. She has a number of publications and presentations and a number of awards, honors, and achievements. She was the immediate past president of Tamil Nadu IDVL and past secretary 2015-17. Apologies again. She is a PhD guide for the Tamil Nadu University. She has authored 3 chapters in textbooks and presented papers in international conferences like World Hair Research Society meet in Scotland, Edinburgh. She's a member of IDVL and various other associations, and her areas of interest are academics and research, community health services. Dr. Smita Prabhu is Associate Professor, Dermatology and Venereology, Manipal. She's a founding secretary, PDAI convener, IDWEL KN, Associated Editor, Coordinator, SIG, Female Genital Dermatosis. Her areas of interest are psychodermatology, female sexual dysfunction, vulvodermatosis, and clinical dermatology. She has a lot of achievements, authored 90 articles, contributed more than 12 chapters, Associated Editor of Handbook of Psychodermatology, recipient of Research Grant IDVL 2019, and winner of National IDVL Quiz Galderma Award for the Best PG South Zone in 2001. Dr. S.V. Kavita is presently affiliated as an Associate Professor of DVL, Gandhi Medical College Hospital, Hyderabad. She has a number of publications and presentations, and she has been awarded the Best Paper Award in Agra. She was a Joint Secretary, Treasurer, and CC member of TSIA DVL 2021. Her areas of interest is clinical and female dermatology. So our panel discussion today, as requested by Dr. Bhumesh Kumar, is going to be on vulvar pain and vulvodynia, malignancies, surgeries, and inputs from the delegates. I always start with the take-home message first. And the take-home message is, all vulvar disease has a diagnosis. And when we make a diagnosis of non-specific vulvitis, it actually is a dustbin term and should be delegated there for eternity. Because these are the patients who do not get well. When you don't bother to do your diagnosis or do the investigations, as Dr. Vani showed us so beautifully in the previous, and Dr. Somesh Gupta also showed us how many investigations are important, we need to thoroughly work up the patient. The panelists have contributed beautiful cases, and we are going to go through all of them. And we hope that you enjoy this panel discussion. So this is the first case. So Dr. Smita, would you like to take it forward?
Yes, ma'am. Thank you, madam. And thank you, organizers. So without much ado, this lady came limping into my OPD, and she had severe pain, couldn't sit or stand. And on history, she said she had these lesions for the past 5 days, which were progressively increasing in pain. And on examination, this is what I saw. She had multiple pustules and vesicles with pseudo hypopyon sign, severe pain, erythema, and edema of the vulva. And we had an initial diagnosis, and there was also vaginal discharge, yellowish purulent vaginal discharge, which was seen pooling outside the vagina. So my first diagnosis was some bacterial infection, perhaps folliculitis and vaginitis. But then I could see a few of the pustules were sort of grouped. So kept diagnosis of herpes simplex, first episode at the back of my mind. History was not conclusive for herpes, recurrent herpes, and husband also had no lesions in history, which we often don't find. So what we did was gram stain culture of the discharge, and we sent for HSV PCR typing also. But on hunch, I started her on amoxicillin 500 QID as well as valacyclovir acyclovir 400 milligram TID. And in 3 days, the report came as Streptococcus galacticiae as well as PCR was positive for HSV1.
Can I stop you there, Dr. Smita?
Yes, ma'am.
Okay. Any other differentials from the other panelists? Dr. Kavita?
Yes, ma'am. Folliculitis and herpes are 2. And in pregnancy, in the first, I think it's 11-week pregnancy. Common diagnosis, those 2.
Okay. Anyone else, Dr. Dhanashree?
Diagnosis of chancroid also should be considered in view of multiple ulcers, but here they are more or less grouped. So
and they are vesicles
Vesicles,
lot of
yeah.
them are
So
vesicles.
herpes and folliculitis would be my differentials here.
Okay. And now Dr. Nirmala Devi, anything?
Ma'am, good morning. No, ma'am, I still consider herpes only in my first diagnosis.
Okay. How would you manage this case? So two important things: primary, 11 weeks, and also herpes. So, Dr. Smita, how did you manage this case? I think you said
Yeah,
valcyclovir.
madam, I started her on amoxicillin 500 TID as well as acyclovir 400 TID. And she was asked to do saline sitz bath in tolerable warmth of water. And I actually didn't give her painkillers because of her pregnancy, but she improved in 1 or 2 days. Topical also I didn't attempt because the whole area was full of discharge and it was looking wet.
Anyone else has to add anything to the management?
Ma'am,
No?
genital herpes is one condition where the topical 5% acyclovir cream also works.
Okay.
Just as a, I mean, it's not a first line, but as a placebo to the patient because they expect something on topical to be applied always, and they get something like this. And also to avoid superhead infection to restore the flora, we can add the lactobacillus supplements, ma'am.
All right, that's another topic in itself, the lactobacilli, but thank you for bringing it in. And I wanted to know, what is the safety of antivirals in the first trimester? Anyone, any of our panelists?
As such, there is no level of evidence, madam, that as causing any sort of complications in the neonates. So as of today, antiviral seems to be, and especially acyclovir seems to be good in the first trimester. In all trimesters, especially in first, second, it's safe actually.
Yeah,
and it's better to give in the first trimester because it's a primary first attack of herpes.
Supposed to be category B, and there is a large study, Scandinavian study with some 3,000 pregnant women, which didn't show any neonatal side effects or fetal side effects. Though isolated case reports may be there. So it is actually we have to outweigh the benefit and give if needed.
Okay. So is it dangerous for the patient to have the herpes in the first trimester, or is it more dangerous to have it in the second trimester or the third trimester?
Third trimester.
Third trimester.
Because of the outcome of the fetus, right?
Yes.
Okay. So acyclovir studies have shown that acyclovir or valcyclovir is not associated with an increase in birth defects, and limited data exists for famciclovir, and therefore it would not be considered a first-line choice for treatment of herpes during pregnancy. And pregnant women who acquire HSV as a primary infection in the latter half of their pregnancies are at a greater risk for transmission to the neonates. So the reason Dr. Smita Prabhu gave us this case is because if you know that we are talking about vulvar pain. So this is one of the commonest causes of vulvar pain. Can you enumerate, Dr. Nirmala Devi, the other causes of vulvar pain?
Ma'am, other causes with lesions and without lesions, class 5. Mostly with the with lesions we have been here, deliberations, ulcerative diseases, discharges, infections.
Can you speak a little louder,
but then,
Dr. Nirmala Devi?
Ma'am, can you hear, ma'am? No.
Can you speak a little louder, please?
Yeah, I am speaking louder, ma'am. Is it
okay? It is
yes,
audible.
Now, yeah, the keloids, the scars in the
closer to the screen or mic. That helps.
Yeah, now is it okay?
We cannot see your face.
My
Dr. Nirmala Devi.
On only, I don't know what.
I can see the upper half of your head, not the lower half.
Ma'am, how about
Anyway,
okay,
please
ma'am,
carry
can you
on.
hear me? Yeah.
Very clearly
keloids, should in keloids, tendencies, everything, and dynia also include, ma'am. There's something called dynia syndromes.
Anyone wants to add anything? Dr. Kavita?
Contact dermatitis we can think of, madam. Either it could be an irritant or an allergic contact dermatitis, apart from the infections and discharges. And any history of any trauma also can cause pain to it.
All right. Dr. Smita,
Inflammatory
want to add?
disorders like
Dr.
lichen
Kavita,
sclerosis.
yes.
Inflammatory disorders like lichen sclerosis, lichen planus, mostly erosive lichen planus. They're also present with vulvar pain.
Okay. Dr. Smita?
Vulvodynia is one like undiagnosed cause in most patients.
Okay, so we'll come to that. Dr. Dhanashree, anything more to add?
Even vulvar malignancies can be painful. They can present as vulvar pain.
And in children, especially sexual abuse or even foreign bodies can give you the vulvar pain.
Yes.
Okay, so now we are going to the next case. Have you all seen acyclovir resistant HSV? I think Dr. Somesh Gupta had mentioned it. Have we, all of us, seen any HSV resistant cases? I have not seen any. I just thought it was very interesting that there are HSV resistant strains. So they should be
Extremely
considered.
rare, ma'am.
Have you seen any?
No, ma'am. No, I have not seen so far in my practice.
Yes, but we
I
must
have
think
seen
of
one.
it.
Yes, ma'am. One case where acyclovir is given for 6 months, and later she continued without advice for 1 year. Still, there are recurrences in the lesions.
So then there is an existence of HSV resistance, of acyclovir resistant HSV, and it should be considered, especially when a patient who has been previously exposed to prolonged acyclovir therapy does not show signs of lesion improvement while on acyclovir, or new lesions appear while being on acyclovir prophylaxis, like Dr. Kavita just mentioned. And also, these patients are treated with cidofovir or foscarnet. So we come to the next case. This was a case of a 45-year-old recently divorced, pain since 10 years. This was my case. On clinical examination, she had a total normal vulva, and her pain was in a stage of 8 out of 10. So how would you proceed with this examination? Dr. Kavita?
Yes, ma'am. First, to rule out the infections, all the causes of the regular causes of vulvar pain, like infections, inflammations, as we already discussed, like common causes, candidiasis, and other bacterial infections, folliculitis, lichen sclerosis, lichen planus, all those causes. And once we rule out everything and we cannot, after exclusion, we can come to a diagnosis of vulvodynia.
So you would examine the patient thoroughly?
Yes, ma'am.
Okay. Dr. Dhanashree?
Yes, madam, I will agree with her. First, I will like to rule out all the known causes before coming to the diagnosis of vulvodynia. And even I would involve gynecologists here to do the proper examination of this patient.
So this is one question I'm asking all of us dermatologists. Do you think it's time we all learned how to do a good per-speculum examination? And how many of the panelists do a per-speculum examination?
I do.
Anyone does?
Yes.
Who does? I can't see all.
I do, ma'am. Smita.
Smita does.
I do, ma'am.
Kavita does. I do.
Many times, not for now. When we see the normal vulva, we tend to overlook the speculum examination. When there is a discharge of,
but do you do a speculum examination?
That's what, ma'am. For when there is a discharge of ulcer, we generally try to.
I'm sorry.
Overlook many times.
No, I'm sorry. My question was not clear. My question was, as dermatologists, do we know how to do a per speculum examination, and do we do it when required? That was my question. So
Yes,
three of us said, yes, we do.
Yes, ma'am, we do, but not 100% of the times.
But you know how to do it.
Yes, ma'am. We have been seeing the cases.
Exactly. So the take-home message here is, I think it's time all we dermatologists learned the sizes of the speculums and how to use a speculum and how to examine, because a lot of time you don't have your gynecology colleagues around and the patient is not going to come back repeatedly. So it's time we all learned the per speculum examination. Okay, so we said that we are going to examine the patient. So here you can see she's totally normal looking. So you would say, oh, you're very normal. But the very important thing is that we need to open out the vulva. If we don't open out the lips, this is what, when I opened out her lips, I saw. So I purposely said that she was a normal vulva, but when I opened up her lips, what would you see in this? Anyone can describe it? Do you see anything unusual?
Yes, ma'am, fox fordyce spots. I could see lesions like fox fordyce spots on the mucosal side of the labia majora,
Okay.
as well as labia minora, actually.
Near the fourchette, down near the fourchette. Okay. Anyone else? What could your differential be here?
There is a slightly raised erythematous flow near the
Correct. That's here. What would you?
Yes, near the posterior commissure.
Yes. What would your differentials be here?
No, ma'am. We have to consider what's the age, ma'am?
She was 40.
Yeah, we have to keep in mind of vulvar intraepithelial neoplasia also in after 35.
Okay.
And then we have to dealt with the deep history, ma'am. History taking is very important.
History is done. History is done. She's divorced. She had a bad sexual history in the sense that she was divorced from her husband since many years now. And this is just a recent occurrence.
Okay, ma'am.
Dr. Dhanashree, any differentials for this?
Maybe irritant or allergic contact dermatitis also, if she is in a habit of using lot of products like maybe a vaginal wash or something like that.
Right.
But there is erythema also, which is quite evident here in this particular area that you have marked here.
Right.
Are these prominent fordyce spots or they are papillae? I really cannot make out from the picture.
Right. Yeah. Dr. Smita, anything to add?
You can see the area of erythema, ma'am. So erosive lichen planus or any vulvar intraepithelial neoplasia.
So can you all see these grouped papules here? Can you all see?
Yes.
Which I have circled. Yeah. So two things. One, since this, I just said as she had no problem, so that if we don't find any reason, she is a case of vulvodynia. But here, when we opened her up, there was something. The other differential which I would like to add is a HPV, because you can get flat warts which look like this, grouped warts. So that is something else we need to rule out. And also this patient gave a history of lichen planus. She had lichen planus. So what would my next line of management be? Anyone?
It's better to do biopsy, ma'am, first.
Exactly. That's what I was waiting for. So we should do biopsies in any of these lesions which are suspicious and when we have various differentials, because we need to confirm a diagnosis before we go for further management. So vulvar pain can be generalized or localized, provoked or unprovoked. Dr. Kavita, can you tell us about the cotton bud test for checking vulvar pain?
We should ask the patient the spots of her intensity, or where the intensity of the pain is more. And to elicit the pain, we can touch the area of the pain with the cotton bud to examine for the tenderness of the pain, so that we can localize whether it is a clitoridynia, vestibulodynia. To know the area of the pain, we can do that.
Right. So that is known as the cotton bud test. And you have to ask the patient whether her pain is provoked. That means during intercourse or when she's wearing tight clothes, or unprovoked. That means even if she's doing nothing, the pain is there. And if she can localize the area. What is the management of vulvodynia? Anyone? How would you manage a case of vulvodynia? Suppose you found there's nothing.
Ma'am, basically, ma'am, generally all these patients who have pain syndromes without any organic lesions, generally they may
Right.
have affective disorders like to have anxiety or depressive disorders, or there may be some marital problems which will be leading on to very sensitive. So we need to take history, ma'am. The history
Right.
taking is very important, very important. And
Very
generally,
important.
I start with mild sedative antidepressants, ma'am. Initially, anxiolytic effect. Antidepressant with an
Right.
anxiolytic effect. I generally prefer mirtazapine, ma'am, in my patients.
What is the dose?
I start with 7.5 milligram OD, ma'am. After
Right.
every 2 weeks, like I updose it, depending upon the. Mostly, they will be happy with 15 milligram per day.
Okay. Dr. Dhanashree, anything to add?
Madam, I spend a lot of time in counseling these patients, and I also involve the partner in the counseling process. So when they come and if we just tell them that this is nothing, it is normal and you don't have to worry, then the patient is not satisfied. So you have to accept in front of the patient that you accept that it is kind of a problem that she is facing. Then they are little confident, and then I do use pregabalin also in these patients, starting with a dose of say 75 milligrams and up dose to say 150 milligrams, depending upon how well the patient tolerates it. And I also use this tryptoma 10 milligram to start with and increase it up to 25 milligrams. And locally, if it is provoked, like if it is intercourse provoked type of vulvodynia, then I ask them to use a anesthetic jelly topical about 15 to 20 minutes before the act.
Very important points. So you, like a panelist said, that it can be, you may need to give antidepressants, anti-anxiolytics, and we also know that there can be a neurogenic pathway. So pre-GABA, tryptoma, very important. And also in addition, what is very important is pelvic floor muscle relaxation exercises. You need to have physiotherapists who know how to teach the patient how to do pelvic floor relaxation exercises. So we've talked about neuropathic pain where we give pre-GABA, gabapentin, and the psychosocial issues, which is the emotional pain, which you give the anxiolytic. So all the above domains, if affected, must be addressed for optimal results. So we come to this case. Dr. Dhanashree, your case, please take over.
So this lady presented with these lesions. She's an elderly lady, about 61-year-old female, and she had these lesions for a very, very long period of time. So since last about 20-25 years, she was having regular lesions. But currently, what she was facing was severe pain in the lesions, and also it was associated with lot of itching, and that is how she presented to the dermatological OPD. Now, her pain and itching was so severe that it was affecting her daily routine, and it was even affecting her sleep. So she was bothered about this because last 20 years when it was not symptomatic, she did not turn up for the treatment. But currently, because of the aggravation of the pain and itching, she was here in the clinic. So looking at it, when I palpated it, when I saw it, there are lesions present on both the labia majora, as you can see here, and it is more marked on the right side as compared to the left side. There are tiny perifollicular cysts that are present on the surface, and on palpation, it was tender and firm in consistency. So a long-standing lesion which is firm in consistency, tender on palpation, and associated with symptoms of pain and itching. That is what I was dealing with. So considering the consistency, I thought of say a hypertrophic scar or a keloid type of lesion because it was very, very chronic in nature and it had not affected her otherwise. So her intravaginal and per speculum examinations were within normal limits. So it was limited only to the labia majora. So that
What were your differentials when you saw her?
First one was a scar, a hypertrophic scar or a keloid. That was my first differential. Then I also had thought of conditions like Crohn's disease, which can present like this labial swelling, but she did not have any other knife cut ulcers, or she did not have any other GI symptoms. So metastatic Crohn's was one possibility that was on my mind. Chronic lymphatic swelling, like chronic itching, etc., leading to this kind of firm swelling, maybe underlying lichen simplex chronicus, which has led to this. So these are few of the possibilities I thought of. Even hidradenitis suppurativa, but she did not have any nodules. On the left side, we could see few nodules, but there were no sinuses, no discharge. So these were few possibilities that I thought of. Yeah.
Anyone else can add to any differentials, or these were good? Anyone has anything to add?
Filarial and filariasis.
Filariasis is a very important differential to think of.
LGV, lymphogranuloma.
Secondary lymphedema, ma'am.
Yeah, but I think she mentioned.
Yes.
She mentioned secondary
Pseudofolliculitis.
lymphedemas.
Yes, ma'am. Pseudofolliculitis can leave behind scars, ma'am. But then usually it will be papillary, not a continuous.
And it won't be a continuous indurated area like this.
Yeah.
Right.
Post-tuberculosis, ma'am.
Very important. Very important.
Very artificial tuberculosis, post-tuberculosis.
Orange appearance is visible. So I was thinking more in terms of lymphedema. And if there was recent aggravation of pain, we could even have thought of subacute cellulitis.
So excellent differentials, excellent differentials. So Dr. Tanashi, in half a minute, you have to tell us what was the what you did next.
Yeah, we tried the potent topical steroids, and then we also did cryotherapy for this patient. But in say 3 to 4 weeks time, we found that everything remained just the same. We had thought of giving her intralesional injection, but patient was not ready for that. So we referred this patient to plastic surgery. So similar to what we do for earlobe keloids, these plastic surgery people excised it completely, and immediately after excision in the wound itself, they had given intralesional triamcinolone acetonide, and patient is doing quite well as far as the symptoms are concerned, and there is no recurrence. She's been followed up for last 2 years in the plastic surgery OPD, so the results are excellent in this patient.
How, Dr. Danashi, did you look up how common are keloids on the vulva? I have never seen such keloids.
I also had never seen such a keloid before.
Are there any reports?
There are like vulval keloids, there are reports, but not very common. It is very rare. And this was a spontaneous occurrence. There is no history of any previous surgery. But this patient gave a history of keloidal lesions elsewhere on the body actually, after a minor trauma. So that led us to the thought process of a keloid as a diagnosis in this patient actually.
I think you need to publish it. It is really a very good case, and you have beautiful pictures. So it needs publication.
Yes, ma'am.
So this is my case of, as Dr. Dhanashi mentioned, Crohn's disease can show you a similar picture. So this was my case of vulvar Crohn's disease. So please also look out for Crohn's disease, because it is not as uncommon as we think, metastatic Crohn's disease. Okay, case 4.
Yeah.
Dhanashi, this is your case again. So a minute for the presentation.
Yes, ma'am. So she was a 69 years old female, and she had these itchy and painful lesions in the vulval area. So this was a short history, unlike the previous patient. It was only there for 3 to 4 months. So she was with a gynecologist who gave her some topical estrogen creams and a lubricant jelly without any relief, and hence was referred to me. So when I first looked at this patient, I saw that there was a plaque, there was erythema, there was hyperpigmentation, scaling, and few erosions on the surface. So I had thought of 2 possibilities. One was lichen sclerosus et atrophicus, and also I kept in mind the possibility of lichen planus also, because there was a bit of hyperpigmentation and a purplish hue here in the upper part of the plaque. I put her on topical potent steroids for 1 month, but after 1 month, I found that there was no improvement whatsoever. The itching did not decrease, the lesions did not improve, and hence I subjected her to a punch biopsy.
Can you talk about the dermoscopy? You did a dermoscopy?
So we did a dermoscopy. Actually, that time we did not know what we were dealing with, but the dermoscopy then we correlated after we got the histopathology report. And what we saw in the dermoscopic examination was, you can see that there are white dots like things here. Then there are areas where
what do the white dots represent?
One minute, ma'am. And then these thick cords, and there are these clear structureless areas which we could see cloud-like areas. So this is suggestive of kind of extramammary Paget's disease, and these are the openings of the apocrine gland ducts.
And these lines, these bands,
cords, right? Yeah. So
what are they? What are these representing?
Again, the same like extramammary, suggestive of these are the hallmark features of an extramammary Paget's disease.
Okay. And can you describe your biopsy quickly?
Yeah. So the biopsy, the H&E staining showed these Paget cells, which you can see that there are large cells in groups. They have a clear cytoplasm and a large nucleus. Forming glandular structures also, and we did a spatial stain, that is cytokeratin 7 stain, which also showed positivity in this particular patient. There are a few more stains that we have advised, but I don't have the follow-up of that because patient is still under evaluation. So the diagnosis was of extramammary disease, CK7 positivity. And another marker which was done in our setup was HER2, this thing, but that was also positive in this patient.
So this is a very important case you have contributed to this panel discussion, because it looks like a classic eczema. It looks like an eczematous dermatitis, which you keep treating with steroids. But remember, if it doesn't respond, please do a biopsy, because you'll be surprised of how many cases of extramammary Paget's. I think all of us have seen extramammary Paget's disease, right?
Yeah.
Most of us have seen extramammary Paget's. So it's not that uncommon. It's just that we are not publishing it, but we are all seeing.
So when there is a steroid responsive dermatosis, it responds really fast. Like if you have a diagnosis,
right.
Like so if you don't see any response, don't hesitate, or don't even
take a biopsy.
To take a biopsy, and maybe if you've taken a biopsy and if your patient is not responding, you may do a repeat biopsy because you might have missed.
Right.
So that important message has to go here, that anything inflammatory or steroid responsive you're suspected but not responded dramatically, always think about
it. Right. What are any of the other members, what are the importance, what is the primary source of this extramammary? Because we have to find out what is the primary source from where these Paget cells are coming. So Smita, can you elaborate?
Mammary Paget's usually ductal, this is there. So any ductal malignancy has to be ruled out. Even internal solid cell malignancies, anything to do with adenomatous cancers have to be ruled out.
Right. Dr. Kavita?
Mostly from rectal malignancies or urinary bladder malignancies. They are the usually common primary sources.
Or it may be a primary source. It may be just the primary, cutaneous.
Cutaneous.
Yeah.
From these.
Dhanashree?
Yes, so for secondary Paget's, extramammary Paget's, these two, that is colorectal and genitourinary, and also we have to examine the breast of the patient
exactly.
and do the mammography, because maybe a patient may be having not mammary Paget's, but she may be having a CA breast, and this can be a secondary extramammary Paget's disease. And to differentiate between the two, in addition to CK7, CK20 histochemistry staining also should be done, because if it is primary, then CK20 is likely to be negative, and if it is secondary, then CK20 positivity may be seen in the patients.
Right. So it's very important to find the primary cause, where it's coming from. So the stains are very important. And also the further investigations, you do an ultrasound of the abdomen, you do a mammogram, you check the bladder, you do the stool for occult blood, you do your urine examination, you do a cystoscopy, you may do a rectoscopy, because you have to find out the primary cause. So we'll just end this thing because we have a lot of the other cases. So just to tell you, it's a rare, slow-growing cutaneous. Prognosis of patients is usually good because tumor cells are in the radial growth phase for a prolonged duration, and a majority of cases are treated in the stage of C and C2. However, once it invades the dermis and becomes invasive, then they have a high metastatic potential. Also, surgery will give you almost a 60% recurrence because you cannot see the micrometastasis. These are the treatments of chemotherapeutic regimes, and in a very early case you can try imiquimod. We'll end this case because we have more important also cases. So now we come to the malignancies. Dr. Kavita, please take this over quickly.
Yes, ma'am. This is a patient whom I'm following with depigmentation of the vulva. Previously, she is diagnosed as lichen sclerosis, and she comes for follow-up once in a year. And once she came again with recurrence of her pain and pruritus in the vulval area, and I noticed to see this eroded reddish nodular lesion on the left side of the labia. And again, I took a biopsy. Her previous biopsy 3 years back was lichen sclerosis. When I took the biopsy from this particular area, I got to see it as vulval intraepithelial neoplasia differentiated type.
Right. So, Dr. Kavita, can you tell the listeners that when should you biopsy these suspicious? What made you suspect the lesion? So, which are the clinical criteria where you should be doing a biopsy to rule out a malignancy?
When clinically we see either an erosion or an ulcer or any hyperkeratotic lesion, thick and whitish plaque, and on a previously normal or a just depigmented vulva, when we see these clinical criteria, and when there is a continuous pain, a persistent pain in a particular area.
Dr. Nina and team,
Yes.
we are just 5 minutes away from schedule.
Yes, we
You
know
can
that.
continue.
Then
Yes,
we can do the
thank you.
biopsy of that area, ma'am.
Right. So it was a squamous cell carcinoma.
Well, yes, ma'am.
So the clues, like Dr. Kavita said, and the incidence of differentiate when in untreated lichen sclerosis is about 4 to 7%. And treatment, yeah, this is very important that clobetasol propionate is the gold standard for treatment. I won't go more in detail, and it's also safe in children. And the non-steroidal are pimecrolimus and tacrolimus. And on unresponsive areas, you can also, after ruling out a malignancy, do intralesional triamcinolone. Okay. So this is another case where we are talking about surgery. So this was a case of lichen planus, of mucosal lichen planus, which was operated, and she was sent to me 3 weeks after surgery in order to prevent the fusion again. So this was lysed, and she even in 3 weeks, even giving her treatment, it fused again. So here what I wanted to emphasize is that lichen planus is a very destructive disorder, and surgery is very specialized. And this patient had undergone surgery when her lichen planus was very active. It was not being treated, so you cannot do surgery for a lichen planus which is active because it's going to fuse. So this was a quick take-home message. I'll take you to the next. So I think this is Dr. Nirmala Devi, quickly.
Dr. Kavita, madam.
Oh, Dr. Kavita, sorry.
Yeah.
Next case,
It's actually a
In 1
77
minute. Yeah.
The 77 years old female madam, which she was kept because she was having really a persistent pain always for the past few years. So she was also being treated for the E. coli infection, and she was repeatedly kept on antibiotic therapy for maybe more than 6 months. And she was also using estrogen, topical estrogen cream for that burning sensation which she was being complaining. So she was using this estrogen cream weekly twice for the past 2 years. So when she has come just 10 days back, when she has come, I've just seen this curdy white precipitate sort of thing. So when usually I thought initially, like, because it was really painful, so I just treated her like thinking it as cutaneous VVC, vulvovaginal candidiasis. So yesterday when I happened to see her, when I discussed with our Kavita madam also, like there was an underlying sclerosing sort of thing, like lichen sclerosis. So
she has an underlying lichen sclerosis, which is very evident.
Yes, madam.
Yeah.
So presently she's been given her antifungal therapy.
Okay.
And I advised her to go with sitz bath.
Okay. So this is just to the panelists. How common is candidiasis in a postmenopausal? Smita? Yeah, whoever said it, ma'am, please.
Ma'am, I'm Dr. Nirmala.
Sorry, yeah, I can't see you. Yeah.
Yeah, secondary candidiasis is very common, ma'am.
In postmenopausal?
Ma'am, this any damage to the epithelium predisposes to opportunistic fungal infections. But then even the appearance of LSA itself, because of its appearance, it mimics candidiasis. That's what I have found many times. It's not true candidiasis.
Usually candidiasis is rare in postmenopausal.
Kavita?
Yes, ma'am.
But then they apply something and come, ma'am. Usually, if they irritate the skin, they try some native treatment or GP.
In
Dr.
postmenopausal, candidiasis is less common, ma'am, because of due to the low estrogen. Unless they are severe diabetics, occasionally we can see it. Otherwise, it is less common compared to the before 40 or 50 or 40 age group.
Exactly. So in a postmenopausal, you will not see candidiasis because of the pH is very high and that does not support the growth. In this patient, possibly why she developed candidiasis because she was using estrogen and that must have reduced the pH. Yes. Also, because the patient has lichen sclerosis, a lot of time when we are giving them topical steroids, they can get super added. But the take-home message is in a menopausal, that's why I put this case. In a menopausal woman, to diagnose candidiasis, you better be very, very sure of your diagnosis because it is not a common diagnosis. We randomly are giving fluconazole for everything which is itchy. But in a postmenopausal, please do not think of candidiasis unless you are sure of what is the primary event which contributed to it. And like Dr. Kavita said, diabetes is one of the very predisposing factors, and I have seen with steroids. Okay, this is the last, very fun. Nirmala Devi, in 1 minute we have.
Yes, ma'am. This lady was a 42-year-old female who had attended our OP few years back with just what kind of protuberant papillary growths along the labia majora, and then she had discharge from the vagina
also on the perianal area.
This is actually the perianal lesion came after 6 months, ma'am. When she came initially, she didn't have any other lesion.
Okay.
So she was referred to the sexual STA clinic. So there they investigated with the RPR and the TPH and everything. But then the test came out negative. But then she was lost to her follow-up after that. Maybe she would have gone to a GP, I think. She had a resolution. So generally the GPs, they use steroids, you know. The Dexa
and what was your diagnosis finally?
Then after 6 months, she came with oral and as well as perianal erosions. That time we could able to do the biopsy and made the diagnosis of pemphigus. It was the differential diagnosis was actually again we should include SJS also, Steven Johnson syndrome as well as this one. So the biopsy gave us the clue. There was eosinophilic abscess in the epidermis, and then DIF was done, and there was a intracellular immunofluorescence. Okay, so she was managed like other pemphigus vegetans, ma'am. Very rarely, in about 2 to 5% of patients, it can involve the genital organs. Pemphigus vegetans can involve the genital. It's a rare case, ma'am.
And very rare.
Yes,
and your differential was also, I think, condyloma lata was your differential.
Yeah, initially, first time when we entertained, it was condyloma lata. The clue is lata is actually, condyloma lata also we included. That's why we referred her to the STA clinic in the initial period. But not in the second visit, ma'am, after 6 months. That time, because of the erosions and painful erosions, we were clear.
All right. So I thank you very much, my esteemed panelists, for your lovely inputs. I'm sorry the time is up, otherwise we could have gone on and on. And thank you, organizers, for giving us this opportunity. And I think on behalf of the panelists also, we have enjoyed doing this panel discussion. And I thank the panelists for giving us such excellent cases and the organizers for giving us this opportunity. Thank you.
Thank you, ma'am. Thank you, ma'am, for all the nice.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am. That was an amazing session. I would like to conclude this by quoting Dr. Oliver Wendell Holmes.
Manogna, thank you. So now we'll move on to the postgraduate quiz, so which is one of the innovative in ASTICON. So I invite the quiz master of this session, Dr. V. Manogna. So she's the budding dermatologist from Hyderabad. I request Dr. Manogna to proceed for the quiz.
Thank you, sir. Thank you for your kind introduction. So now we begin the first session of the quiz, which all of us are looking forward to. And first, I would like to tell the postgraduates that the link for the quiz is provided in the left of the conference screen. And the entry is only for postgraduates and PLMs. And here is a brief introduction to the rules of the quiz. Each session will have 10 MCQ questions. One correct answer has to be marked for each question. And the first 3 toppers in all the sessions together will be selected for the first, second, and third prizes. And the duration of time is 5 minutes for the quiz. And postgraduates will later have to submit the bona fide certificate if they win the prize. And please do not refresh or close the browser during the quiz. And all the very best to all the participants of the quiz. And there are some very, very attractive and useful prizes at stake here. So all the best. I request the postgraduates to kindly start taking the quiz. Now, simultaneously, I take this opportunity to request our organizing secretary, Dr. Bhumesh sir, to take over the proceedings for the felicitation of all the speakers, chairpersons, and panelists for this discussion.
Yeah, Manogna, you carry on. You request the chairperson to felicitate the speakers, moderators, and panelists.
Okay, sir. I request our honorable chairperson, Dr. R.N. Datta sir, Dr. Chandragupta sir, and Dr. Vijay Zawar sir to kindly felicitate the speakers for the session. The first speaker, Dr. JVDS sir. Thank you very much, sir. That was a very, very unusual and beautiful ceremony, sir. Thank you very much.
Yeah, thank you, Dr. Manogna. So really, it was a wonderful session. So thank you very much for all the faculties, the nicely conducted with the maintaining time.